Okay, we're live.
Good afternoon, good evening. Welcome to the Reunion Project's first webinar of 2021, COVID-19 Pandemic and Vaccinations, what those of us living with HIV need to know. I'm your moderator today. My name is Wahida Shabazz El. I am, along with Jeff Berry, I am the co-chair, one of the co-chairs of the steering committee at the Reunion Project. And we want to just welcome everybody here and wishing everybody a brighter, better new year. And in Reunion Project fashion, we are not wasting time bringing you relevant and timely information, bringing you trusted voices from the community so that we can have this talks about COVID vaccines centering people living with HIV. So I'm just so pleased to have everyone here. Calvin, if you could move the slide so folks can, if you could just move that slide. Perfect. So that's who I am. So some of you know me, some of you don't. Welcome. First of all, before I even, I'll go ahead and thank our funders. These are the folks who help, besides you all, these are funders who help keep the Reunion Project up and running. They're all equally as important, and we couldn't do this work without them. But what I like to do right now is sort of like do a roll call. I know everybody's in here, you're all muted, and that's because we have maybe over 200 participants on this webinar today. We're very pleased about that. But so what we want to do is we're using the mute feature for you all, but the chat feature is open. And we'd like to do like a roll call. We want you to start putting your names in the chat if you care to. Introduce yourselves, tell us where you're joining us from, and we'll just yell out some of those names as we see them coming to the chat. So Gina Brown, I see Gina. Hi, Gina. Gina Brown. Pat Kelly's here from North Carolina. Gina Brown from New Orleans. Folks are coming in. Oh, wow. Elizabeth Bates has raised her hand. Yolanda Diaz from New York City. Here we go. Okay. And so, wow, the chat box is just going. So I'm really appreciating the love that you are giving us, and we're giving that love right back. I just saw Wanda Brendel Moss, Helen Schaefer, and J.D. Davis is here from Brooklyn, New York. People are coming in from Stephen Pablo, Charleston, South Carolina, Donna Marshall, Denver, Colorado is here. Heshi Zeman from Philadelphia. I'm in Philadelphia. Hey, Heshi. Tom Villa is here from Tom Villa, Rockville, Maryland. That's Kyla. Keith Carter is here Keith is from Philadelphia too. Hi, Keith. And where people are just still continue to come in. We want you to continue to put your names in the chat box if you care to. And we're just going to keep calling folks out for another 2 minutes or so. And then we're going to have Vanessa Johnson, who's one of, before we do that, I'll let you know who our speakers are going to be. And we're going to start with, in Reunion Proud style, we're going to start with a grounding exercise for you. But we're going to continue. Helen Zimba is here. Hi, Helen. Good to see you. Forever 21. That's what I always say to her. And folks are just joining us, and we're seeing more and more folks joining us in the chat box. And who else is here? Someone's here from Chicago. Karen from Chicago. Michael Dorish. Hi, Michael. Matt Sharp from Oakland is here. Hi, Matt. I'm just looking through. Karen Bates is here. Jim Clay is here from Portland, Oregon. Christopher Tunstall is here from UNC Chapel. That's North Carolina. And Laura Silas is here from Seattle. Ralph Simon is here from Philadelphia. We appreciate all of you joining. We had over 229 people register for this event. I'm not really sure how many people were able to get on, but we're happy to have you here. And like I said earlier, we're wishing you a brighter, a better, brighter new year. And what we're doing today is bringing you some trusted voices from our community to talk about COVID. So what I'm going to do right now is just move to the next slide. Yeah. and just kind of tell you a little bit about our presenters here today. These are the folks that have come in to help us move our agenda today. We have Vanessa Johnson here with us. Vanessa Johnson, most of us know Vanessa. Most of us know everybody here on this panel. Vanessa Johnson, she is a national advocate, and she is from Washington, D.C. She's going to help. She's going to uh, get us grounded, get us centered, and get us ready to receive this wonderful information. We're pleased to have Dr. Carl Dieffenbach, the Director of Division of AIDS at the NIH. He's also here with us. We also have joining us Reginald Brown. He's a board member at New York Vocal. And also we have Moises Agasto Rosario, treatment director at NMAC, the National Minorities AIDS Council. So we have a very I'm honored to have this be able to be the moderator for this panel of trusted community leaders today. And so we're going to hear from each of them in turn. And so right now, what I'm going to do is turn it over to Vanessa Johnson, and we're going to move the slide. And we're going to turn to, oh, no, I'm sorry. I have to tell you a little bit about the Reunion Project. So we need to go back one slide. Vanessa, give me a second. I'm thinking everybody knows who we are, right? Everybody doesn't know who we are. So I should tell you a little bit about the Reunion Project. The Reunion Project is the national alliance on HIV and AIDS long-term survival. Our growing national network honors the power of sharing our unique stories in collaboration with local and national HIV advocates, providers, and researchers. We convene local, national, in-person, and online events. We create and disseminate reliable and timely information, and we make calls to action and policies around policies that affect long-term survivors of HIV and AIDS. We also strengthen the capacity of survivors to serve as leaders in our communities and in our HIV movement. And if everyone's free to join the National Alliance, and you can just hit up steering committee at reunionproject.net. That is how you contact us. Steering committee at reunionproject.net. And now we're going to turn it over to Vanessa. So could you just, there you go. Vanessa Johnson, thank you so much for being here today. And I don't know about you all, but I feel like I could use a little grounding and centering. So we're going to have Vanessa turn on her mic, and I'm going to turn mine off.
Hi. Hi, everyone. Welcome. I am having some technical difficulty, and that's the norm with Zoom. So just be patient with me, but we will get through this grounding exercise. But first, I need to know if our host, Calvin, will allow me a privilege of being a co-host so I can share my screen. Is that possible?
Yes, I'm sure it is.
Okay, great.
Vanessa, you are a co-host now, so you can share.
Thank you. You can see my, Calvin, can you see my setup? Yes, you can.
I can.
You sure can. Okay. So we're going to do a grounding exercise. Sometimes grounding exercises are steeped in breathing exercises. And disclosure, I'm a person who has attention deficit disorder. At least I have self-diagnosed myself this way. So sometimes breathing activities, I can't stay present enough to be engaged with a breathing activity. So I use a lot of visualizations. And so we're going to do a grounding activity that's based on a visualization. So our visual grounding exercise, I'm going to read the next two slides verbatim so I don't miss anything. And you have the opportunity to sit and listen and reflect on how you're going to participate in this exercise. By the way, if you don't know me, my name is Vanessa Johnson. I am a participant of the Reunion Project, very happy to be affiliated with it. And I'm also a proud partner of Linda Scruggs at Ribbon. Ribbon is now a nonprofit organization, and we love doing the work that we do, especially on behalf of the community. So let's get started. At this stage, at this stage in our lives, we have overcome and conquered a few things that we thought would diminish us. Yet here we are. At a point in our lives, we started reflecting on the good, the bad, and the ugly in our lives. It is at this point in our lives that we start doing that. We're now over the age of 50. We're starting to look back on our lives and just trying to figure things out and get settled. And so, what we have before us is this cactus. It may seem like a reflection of the bad and the ugly, but these reflections enable us to see the hidden meaning, lessons learned, and the beauty that comes from our lived experience. So we're going to look at two. One is to allow you all just to reflect on what we just said, the good, the bad, the ugly in our lives, and what wonderfully magnificent, wondrous, joyful, and you pick your own word, came from a place of pain, hurt, or disappointment you may have experienced in your life. You might decide to jot these experiences down for yourselves or share these experiences with our webinar community via chat. And I will send these all back, kind of see a little typos I missed. But the point is, COVID-19, much like HIV, has revealed the good and bad and ugly of our society. For me, the reemergence of the important role science, medicine, and caring can play in our lives has really been impactful for me. So I'm going to show you this cacti in bloom. Great photographer that works for the National Geographic did this. And it just shows you the hardness that our lives have taken and sometimes the softness that comes out of that. And many of you who may love cactus as your favorite plants will already know what I'm talking about. So enjoy this. It's about 4 minutes. If you'd like, would want you to put in the chat, like what came out of your difficult or challenging lived experience? What was the lesson learned you got? What was the miracle that happened for you? Those types of things. So I'm going to come out of this and bring up
to get high, I gotta move on before the sunlight's gone. Yeah, I gotta move on before the sunlight's gone.
Hello, hope you're still with me. I hope you enjoyed that. The lesson that I got from it was basically to be careful what you reject, because and I'll bring this back up. I'll bring up one more grounding activity. To be careful what you reject, because I never liked cactus or cacti until I saw flowers on them, and then I had a different perspective about them. So that was one of my lessons learned from this activity. But also, it's just a lot. What I said earlier about the good, the bad, and the ugly, and getting from this COVID experience a rebirth and a reappreciation of science and medicine and the things it has done in my life as a woman living with HIV, and things it will do in the lives of others who've been severely impacted by COVID-19. So now I'm going to do a grounding exercise that will bring you back to the present. It's a cute little exercise that I found. And basically, you're going to see a kitten who's escaping a cage to play with a puppy. And this is my interpretation of trying to get vaccinated for COVID-19. So this will bring us back into the present and prepare us to hear the good news about vaccinations. So give me one more second. Thank you for taking that journey with me through these grounding exercises. Hope you enjoyed them both. Please feel free to use them. And I'm going to turn this back over to Wahida, who will
Vanessa, thank you
have the
so
people bring the good news
much.
to us.
Thank you so much, Vanessa. I feel so calm and ready to receive. And yeah, thank you for all of it, for the music, for the cactus, and for the kitties and everything. So yes, I am ready to receive it. I hope that you all are as well, because we're about to be joined by Dr. Carl Dieffenbach, PhD, who serves as director of the Division of AIDS at the National Institute of Allergy and Infectious Diseases. Among his many areas of expertise, Dr. Dieffenbach is a specialist in biomedical research around both HIV vaccines and COVID-19 vaccines. We are deeply honored. There he goes.
Thank you, everybody. It is a real pleasure to be here today with you. I have a short presentation, as you can see, entitled SARS-CoV-2 Vaccines and You. What do we need to know going forward? Next slide, please. So I'm going to spend some time talking a little bit about HIV and coronaviruses, just so that we have a sense of what we are dealing with in terms of the virus families. Talk a little bit about transmission. Talk about a little of the clinical manifestations of COVID-19 vaccines, and then a slide from the guidelines panel of the NIH guidelines panel on coronavirus disease. Next slide, please. So one of the questions I keep getting over and over again is coronavirus vaccines have this amazing level of effectiveness between 94 and 95%. Why is that? And why can't we have an HIV vaccine? And I think it comes down to the differences between the two viruses. And I think that if you think about coronavirus disease and the people that you have known that have had the disease and recovered, we all know people who have also had coronavirus disease and have passed. We also know people that have had coronavirus disease and have remained sick for a very long time. The difference is for HIV, by and large, it is almost uniformly progressive as a disease. We know that the antibodies that the virus makes against the virus in people really don't do very much to help control the disease. And there's constant and relatively chronic viremia, virus in the bloodstream, of people who are living with HIV who are not on antiretroviral therapy. It takes almost 2 years or more to get antibodies to appear that seem to do anything against HIV. HIV has never been cleared from somebody living with HIV, except in the case of people like Timothy Ray Brown that had tremendous levels of intervention required to get to that state. And there is no protective immunity from superinfection. Next slide, please. Coronavirus, on the other hand, is a different type of virus. It's again, its picture is shown there. But basically, the disease comes on like a cold or the flu, and you're sick for anywhere from not at all, there are people that are asymptomatic, to mildly to quite sick. But it is a completely different virus. And because there is this issue with this virus being relatively easy to vaccinate against is part of the reason that we have the vaccines today. The antibodies are quite effective in terms of protecting the person. And we see that in the fact that reinfection is relatively rare at this point with coronavirus in the vast majority of people who have convalesced. So moving on, next slide, please. Spending a moment about transmission and mechanism. Next slide, please. This slide says it all. Airborne droplets, whether by sneezing, as shown here, or coughing, or singing, or talking, is the primary mechanism of spread. I think we can't lose sight of the fact, and this is why masks are effective, because if you had a mask on when you sneeze like that, the particles would not go nearly as far or as explosive. So this picture, I think, really captures the extent of material that comes out of somebody's nose and mouth when they sneeze or when they sing. And you can understand why, if you have virus infection in the nose or the throat, you are quite able to spread the virus relatively easily. Next slide, please. Spending a moment on clinical manifestations of coronavirus disease. Next slide, please. So from the time of exposure till the appearance of symptoms ranges from 2 days to 14 days, with the average time, the median time, of between 4 and 5 days after exposure. And those curves represent different studies in different populations, but it's pretty uniform across nearly all populations and age groups. Next slide, please. So I learned a new word, and this will make it the word of the day. It's the word that means loss of ability to smell or taste. It's anosmia. It's there in the title of the second article. It's a big fancy word. It means loss of smell and taste. I just thought that was an interesting word to know, because I had never heard of it. And this is one of the cardinal symptoms of coronavirus disease, is loss of smell and taste. And that is one of the things that physicians use to differentiate between the coronavirus disease and other upper respiratory tract infections. Next slide, please. So as I indicated at the beginning of this presentation, there's a wide spectrum of disease associated with coronavirus infection. A significant number of people are asymptomatic. They have never have any symptoms. They shed virus for a period of time. They transmit virus, but they are asymptomatic. They have no symptoms, and they develop immunity. You have mild disease, which is upper respiratory tract engagement, moderate disease, which can include pneumonia, severe pneumonia, which requires hospitalization, and then critical illness is this state of serious overactive immunity, ARDS, sepsis, septic shock, organ dysfunction and failure. Neurological complications are part of the critical illness syndrome. And the distribution, to a certain extent, correlates with age and other risk factors. The older you are, primarily over 75, the more comorbidities you have, the more likely you are to be in the severe, moderate, or critical illness component. Being younger tends to correlate more with being in asymptomatic or mild disease. Again, these are gross generalizations, but because there's always exceptions, those are some generalities. Next slide, please. So in terms of clinical presentations, most people present with fever, cough, fatigue, and then this issue of loss of smell and taste. And as you can see there, shortness of breath indicates, and lower oxygen saturation are serious signs that you need to get to the hospital and get on oxygen. Next slide, please. So this is the list of risk factors for severe COVID illness. And I want to focus in on one in particular, and that's immunocompromised. I think that is one where some of the discussions, primarily with the vaccine companies, really got a little, they learned a lot about HIV as we were talking to them about what it meant to be living with HIV or to have HIV. And there was assumptions about what the degree of what immunocompromised was in people living with HIV. Next slide, please. So what we know is people living with HIV that are not virologically suppressed, that have low CD4 counts and opportunistic infections. This is the group of people that are categorized as being immunosuppressed. People living with HIV, being virologically suppressed, taking their medication are not. Many people have CD4 counts well over 400 or 500, and they are essentially as pretty much immunologically normal, compared to people without HIV. So it's important to think about this, is that we compare that as with the general population, people with HIV who are virologically suppressed and have diabetes, hypertension, lung diseases, or are overweight, and they will be vulnerable to severe COVID. But the drivers of this susceptibility is not their HIV, it's their comorbidities. I think it's really important to make that differentiation. People living with HIV are considered by the US FDA as being able to serve as normal healthy volunteers in clinical trials. And I think that was the point that really motivated us in the Division of AIDS to make sure the vaccine studies going forward were open to enrollment to people living with HIV. Next slide, please. Let's talk about vaccines a minute. That's why we're here today, right? So this is a list of the vaccines that are currently either the top or the two that are already approved through emergency use authorization, the Moderna vaccine and the BioNTech Pfizer vaccine. They're quite similar. They're RNA vaccines, and we'll spend some very specific time talking about those. The next two up are AstraZeneca and the Janssen vaccine, or the J&J vaccine. Both of these vector systems, the adenovector that is being used by AstraZeneca and the delivery system or vector that's being used by Janssen, are the delivery vectors that are currently being used by these companies for their HIV vaccines. So again, this is an example where HIV research was a trendsetter and set the path that these companies were then able to capitalize and move forward. One other note about the Janssen vaccine and their vector system, it is already part of a licensed vaccine for prevention of Ebola. And so this is a very safe platform. It has been used extensively around the globe, and not just with those three viruses, Ebola, HIV, and coronavirus, SARS coronavirus 2, but other viruses such as Zika have been used. And then we have the two proteins. Novavax is in trial. Now it is nearly fully enrolled and moving forward. Just a story about Novavax, they are completing a study in sub-Saharan Africa, and approximately 20% of the enrollees in the Novavax trial there are people living with HIV. So companies have been very open to HIV enrollment, and all the others, Janssen, AstraZeneca, and ultimately Moderna and BioNTech, Pfizer, included people living with HIV in their trials. Next slide, please. So this is the way the messenger RNA vaccine works. It's so different than the other vaccines, I thought it's worth thinking about. Messenger RNA is exactly what it says it is. It's a messenger. It provides information that cells in the body can use to make proteins. So these companies have figured out simple and very straightforward way to package that piece of information into a particle that, when injected into muscles, goes into the muscle and immediately starts playing the role of a messenger and being moved from being an RNA to being uncoded or translated, as we say, into proteins. And the proteins that get made are the S-glycoprotein or the spike protein of the coronavirus that then the body makes an immune response. I just see in the chat somebody got their first Novavax shot an hour ago, and I did miss the rest of the comment. So let me just see if I can find it quickly. They require undetectable, less than 50, and a CD4 count over 200. That's what the participant said. So that's a really great statement for the Novavax company. Next slide, please. So this was the timeline of development for the coronavirus vaccines. It took 5 days to get the sequence and move the messenger RNA into GMP production and preclinical. We started the phase 1 65 days later on March 16th, started the phase 2 in May, the phase 3 in July, completed the study on November 17th, filed for the EUA, and it was approved November 30th, and we've been vaccinating since mid-December. This morning in the newspaper, they said 22 million Americans had been vaccinated. That number will go up by approximately 1 million or so every day. I want to remind everybody that the slides will be available on the website after this. My dear friend Murray just said he's been vaccinated, so congratulations, Murray. Next slide, please. So what do we know about the efficacy of the vaccine in people with HIV? So a quick scan, there hasn't been formal specific analysis of these points. But what we know from a very careful look at the database, there were no statistically different adverse events in people living with HIV compared to other participants in the study that received any of the vaccines to date. So safety is equivalent. The next issue is there appears to be equivalent efficacy in people living with or without HIV, simply because the efficacy was so high. If people living with HIV had a slightly lower efficacy, we would have seen, it would have shown as a subset of people that dropped down to say 80 or 70%. We did not see any inkling of that. Now, there are people that are immunosuppressed, that are people who take immunosuppressive drugs every day for their health. There are people being treated for cancer that are immunosuppressed. There are clinical trials planned to investigate how the vaccine performs in people with this kind of immunosuppression. But these are not needed for people living with HIV. But what we do know is that the monoclonal antibodies, one population that does seem to have a level of immunosuppression are the very elderly. And the studies that have been completed recently by Eli Lilly and the Regeneron Corporation indicate that those monoclonals are quite potent in protecting people, those people that are immunosuppressed, and there's every reason to think that they will be equally effective in protecting cancer patients and other people who take immunosuppressants for their health. At the same time, we're getting ready to start studies where we combine antibodies and vaccines as a way of helping to protect the immunosuppressed while the vaccine takes a little longer to provide take. Next slide, please. Just a word from the guidelines panel. Next slide, please. I think these are very reinforcing messages that I think are incredibly important. The COVID-19 guidelines panel recommends using the same approach for the prevention and diagnosis of severe respiratory syndrome for coronavirus, SARS-CoV-2, infection in people with HIV as with people without HIV. So the same diagnostics work. There's nothing special required to find coronavirus disease in people living with HIV. In terms of managing the disease, COVID-19, that occurs, the panel recommends the same triage, management, and treatment for people living with HIV as those with the general population. So with that, I will stop and turn the panel back to the next speaker for introduction. And I'm looking forward to questions when we get to the end of the presentations. Thank you all.
Thank you so much, Dr. Dieffenbach. And Dr. Dieffenbach is going to stay around because we're going to have Q&A at the very end. And he actually said he wanted to be a part of the community, so he's going to be here for the entire webinar. Thank you so very much. We're going to bring on now Reginald Brown. He's a board member of Vocal New York. He's also a community leader. Reginald Brown's a long-term survivor who's been a participant in the COVID-19 clinical trials in New York. He's going to be sharing his experience about that journey with us today, and we are deeply honored. Here we go.
Wahida, thank you so much for allowing me to share my story, and thank you, Reunion Project, for allowing me to be involved in this. One of the questions that I was asked was, why did I participate in this COVID-19 vaccine study? First and foremost, I participated in this and the 6 or 7 other clinical trials due to the woeful underrepresentation of Black people. Every clinical trial before the COVID-19 trial was for HIV medications. The second reason for wanting to be a part of this study was because I wanted to know what the effect would be on people who were HIV positive. Initially, both Pfizer and Moderna did not want to include people who are HIV positive. Paz Magazine put out the word, and just like the HIV community does, we rose up and fought up and said, yes, you will include us in this study. As a long-term 34-year thriver of HIV, I wanted to know the effect of the vaccine might have on my HIV and my medications. I lead by example to help Black people who rightly distrust the medical profession by publicly revealing my clinical trial participation. The Tuskegee instrument, which ran the Tuskegee experiment, which ran from 1932 to 1972, allowed Black males to remain untreated for syphilis. In addition, there was no informed consent. Every trial that I've been a part of has rigorous informed consent policies, as well as an opt-out options for any time in the future. Another question was, did I have any fear? No, not really. I have little fear of going into these studies because my mother was a nurse practitioner and gave me all of my childhood immunizations. My mother would never hurt me. Healthcare in my family was an integral part of my life for as long as I remember. I realize that every HIV medication I am taking, somebody had to go through a clinical trial for. I do this to honor them and to lay the groundwork for those who come after me. I am number 5 of 30,000 COVID vaccine participants with Moderna. The study is for 26 months. January is my 5th month. I was unblinded in the study on January 20th and found out, whoa, I got the vaccine in in September. There was slight itching at the injection site after the second injection. And after the first and second injection, there was slight lightheadedness, which I would compare to having a dose of cough medicine. The itch was not severe. It wasn't even as much like a mosquito bite. So this, as I said, I wanted to be a part of this because I'm a direct action person. I like to go and shut shit down and disrupt our business as usual. I can't do that this time. So since I can't shut shit down, I lay my body on the line in this vaccine study. I would encourage everyone to take this because, you know what? All I can say is I lead by example. It's not for me to say what you should do. All I can say is I lead by example. So far, I've had no adverse reactions to the vaccine, and it has not interrupted my HIV regimen at all. So, like I said, I'm in month 5, and I did sign on to continue all 26 months because I know how important it is to have as much valid information as possible. So yes, I have received the vaccine. So Linda, Wahida, what else did you want to know?
Oh, you are doing great. There's lots of questions in the Q&A, and we're gonna, if you're done, we're gonna move on and we'll see you all at the end where we're gonna just have a whole lot of questions and answers going on. Thank you so much, Reginald.
But my pleasure.
You are amazing. Well, we're gonna move to the next slide. And why am I seeing my background? I should see a slide because I want to introduce Moises Augustus Rosario. Here we are. So Moises Augustus Rosario, he's from INMAC. He's the INMAC treatment director, and he's a longtime treatment advocate and educator for people living with HIV and AIDS. As the director of treatment at INMAC, he's been a frequent public speaker and a writer in both English and Spanish. He's played a crucial role in ensuring that communities of color have equal access to care, treatment, and life-saving information, and has won numerous awards for his work in the HIV community. And again, we are deeply honored, Moises.
All right. Can you hear me?
Yes, we can. You are perfect.
Well, I'm the one that is honored to be part of this panel. I am a fan of the Reunion Project. I think that the work that you do for those of us that are long-term survivors is very important and necessary. We need to continue building community among ourselves and take care of each other. That's how we have survived for so long living with HIV. So I am HIV positive and I tested positive in 86. So that I have like 34, 36 like regional years living with HIV. And that made me also a long-term survivor. So one thing that I thought you have been getting and gathering a lot of information from, the clinical point of view in terms of the research, and also regarding the vaccines provided by Dr. Dieffenbach. And also you heard about, the important thing that Reginald have done for his community, to enroll in these vaccine trials that, as he explained, we activists had to make sure that people living with HIV were not excluded from participating in the trials. So one thing that you have learned a lot, and I think that what I can do here is kind of to recap on the things that are very key and important for those of us living with HIV. And that is not only about the clinical information, but it's also about the things that we need to do in terms of taking care of ourselves, taking care of our mental health and our, monitoring our HIV and other conditions that we may have. We have, as long-term survivors, we have more than a PhD in knowledge that we have developed in terms of how we take care of each other, how we take care of our health. So this is, the things that I will mention, I'm sure are not new for most of us, but that sometimes, we need to see them in the context of like, let's say now COVID-19, which is a different condition that we are faced with at this time of age. So we have learned that people living with HIV on effective antiretroviral therapy, as Dr. Dieffenbach mentioned, those of us that are virally suppressed and that have high CD4 cells, they they do not appear to be in greater risk as those for COVID-19 compared to people that are not HIV positive. So it is very important for us to be undetectable. And with that undetectability, I think it is, as he said, it's important that during these times that we were facing COVID-19, that we are very thorough about keeping a supply of 30 days of our antiretrovirals. And not only our antiretrovirals, now as a 50 years old, 55 years old, I wish I was 55 years old person living with HIV, I have been adding to my arsenal of medicine other medications for my heart conditions, for my arthritis condition, for my AC1. So there is more than suppression, that I have to be taken care of. And with this, it's the medications for those other comorbidities that you may be facing. And also, your doctor appointments with those specialists that attend to those comorbidities. Dr. Dieffenbach says something very important about, people, if you have HIV and you have a comorbidity like diabetes, cardiovascular disease, if you are affected by COVID-19, the risk of more adverse reaction to the disease is higher. So that's why, even if you have HIV and even if you're undetectable, even if you have high CD4 cell, it's important that you keep, abreast of your diabetes, that you keep abreast of your cardiovascular, that you keep abreast about, your weight. And I managed to lose like a couple of pounds, and my AC1 went down during this time. So, these things are important too in the way that we confront taking care of ourselves with the conditions that we have. So also it is, so it's important that you keep that clear. I may be suppressed, I may have, but I need to check with my specialists, my doctors, and those other medications I need to have, and continue living a healthy life, being holistic about what you do. And that also include exercise. It's important that you keep it moving. You don't stay home being isolated or depressed, but that exercise boosts your immune system. Exercise is good to lose weight. Weight is no good for diabetes, it's no good for cardiovascular, and it's no good for COVID-19. So, and you don't have to go to a gym and start doing weights. Just walk 30 minutes every day. Try to do that. Go get fresh air outside and have, if you can run, have a run, but don't stay without not exercising your body. You need to do that. Also, mental health is important for this. If we don't take care of our depression, or if we are anxious, these things tend to, get in the middle of us taking good care of ourselves. And, those of us like long-term survivors, people living, 50 plus, we have, a lot of us confront isolation. And, as we confront isolation, because we all know the reasons here. We lost our friends, we're getting older, we're facing self-stigma about our aging, our HIV, about our sexual orientation or gender. We sometimes we have so much baggage. And also, living with HIV for a long time, we know we have PTSD, we know we have to deal with trauma. And, it's important that we don't lose perspective of that. And that we keep a positive outlook for what we're facing today. If we survive HIV, we can survive COVID-19. And if we have a good therapist, if we have if we have a therapist, if we have a support group or a group of friends that you can call and you can talk and you can process, and you can, even if it's, you get a bunch of friends online to watch a movie, you can do that now with the technology and chat about the movie, but keep your mind busy. And keep yourself connected with your community, with your family, and with your friends. And that way you will not be victimized by the disease. You will not be victimized by having to be at home, and you will have a positive view that you're taking care of yourself, that if you're home, if you're protecting yourself with the mask, if you are following all the recommendations, you are doing fine. you're surviving and you're thriving. You know, it doesn't need to be like, you know, victimizing myself about what is going on. Other things that I think is important, as I mentioned, with the relationship with your care, you know, talk to your doctors, check your appointments, make sure that if you have to do telehealth, that in advance, you talk with the people at the doctor's office and you arrange a way that you know how to use it. You know, sometimes, and it happened to me, I missed the opportunity to see my doctor because I ran into technical problems with their telehealth system. So some of that little knowledge or asking for help would be good, but don't be afraid of it, because you remember, you're thriving, you're surviving. So other thing that people ask, if people with HIV, if we will have, you know, a worse or you know, worse than other people disease reaction or symptoms. And as we mentioned, again, you know, it all has to do with how the condition of your immune system, and if you have any comorbidities. And the evidence, you know, goes to, you know, we're parallel to people that are HIV negative. If we have a good CD4 and viral load, and we are taking care of our comorbidities, we'll do okay. If you have less than 350 CD4, or if you have high CD4, you know, less than 350, and you're not virally suppressed, you know, you may react, have a more severe COVID-19 than the others. Very quickly, I already mentioned the 350. I already mentioned viral low. You know, and in terms of preventing, you know, it doesn't hurt to quickly go through the things that we can do. For example, you know, those of you that are in New York and have to take the subway, you know, make sure you keep distance with people. Don't touch things around you. If you can wear gloves, wear the gloves. But also, you know, keep the distance at the door when you're in the car. You know, it sounds like you have to be aware of so many things, but again, you know, we're very smart and we are surviving. So we're very happy to do all those things. Wearing the mask is critical. Also, wearing the mask and keep it clean. Some, you know, I heard some people that forgot to clean it, and suddenly, you know, with the humidity, there was some fungus in their mask and they got an infection or something. Keep your mask clean. This is important too. Also, don't go to crowded places. If you can hang out with your friends online, hang with your friends online, get the phone, talk to them. And if you need that, you have people that you have to see, you know, just follow the distance. If you go into a restaurant, just sit on the opposite sides of your table, and have your mask all the time, except when you're eating, of course. Okay, so clean and disinfect. You know, don't go crazy about it. Like, you know, some people get very obsessed about it, but, you know, just use your common sense, right? Surfaces at your home, if you live alone, you clean them, you keep them clean, that's fine. If you go outside, you know, have your wipes with alcohol that you can, if you have to touch any surface, that you can disinfect it. Cover your mouth if you cough. And also, you know, do it like with your elbow. That's like the right way to do it, so it doesn't get in your hands and then it gets to other people or other surfaces. So in terms of preparing, I already talked about keeping a good stock up of your antivirals and your other medicines for your other conditions. And also your vaccinations, get your flu vaccine. It does help. It just like, you know, you don't want to be having flu and then, you know, get COVID-19, that will make things worse. So just keep up with your vaccinations also. And food. food, be smart about grocery shopping. You can have it delivered. I go to the supermarket because it's the only, I go out for the supermarket, pharmacy, and the doctor's appointments. That's it. Sometimes to walk around the neighborhood, get some fresh air, but just make sure. When I said about the vaccines, also the shingle vaccine is important. The pneumonia vaccine is important. So all vaccinations that you have to have because you're older than 50, just have them and be proactive. Ask your doctor. Sometimes they don't ask and they don't look the chart. So make sure that you have them. Thank you for whoever highlighted the shingle vaccine. Also, if you feel, just making just a summary of it, wash your hands, keep your meds, get your immunizations, take care of your mental health, make sure you connect to community, you connect to friends, to family, make sure that you eat well, that you don't eat like, fast food or, eat well, healthy. So you keep, you also dealing with your weight. And that, as I mentioned before, it will also reflect in other things that you need to take care, like the diabetes and other conditions. So mental health is important, as I said. And if you don't feel well, make sure that you call your doctor, just review, like Dr. Dieffenbach talked about the symptoms, keep those in mind, not to obsess about it, because sometimes you find people that get hypochondriac and you mention some symptoms and 5 minutes later they have them. That's all right. We all been there. I have hypochondria sometimes, but just keep it real, right? And touch base with the doctor if you need to talk about any symptoms that you feel. But don't neither get obsessed, neither dismiss them, right? There is a balance to everything in life. So just be prudent and smart about it. And I think I'm wrapping up. And I think that's all I had in terms of like wrapping up with the things that we should go home with. And now looking forward to the Q&A. Thank you for having me.
Feel so much more equipped and know how to take care of myself so much better. Thank you so much, Moises. I'd like to thank all of our panelists, and we're going to bring all of our panelists back on. And while we're doing that, I just want to just recognize that a whole lot of folks have joined us. I believe I saw about 141 people. Connie Dukes, Chris Roebuck, Butch McKay joined us, Tana Pratia, Jesse Mona Cartwright, thank you for helping us with the registration form. Michelle Lopez has joined us, Karen Fernandez, Rob Reister, Lynn Kidd, Jeff Berry. We are family and we are here in the house. So we're gonna, let's see, Linda. Okay, so the doctor's here. Dr. Dieffenbach stayed with us. Linda's here. Our panelists are here. Reginald Brown, Moises, and we're going to start asking some questions. You all have put some great questions in the chat box. And so I guess in the Q&A. So I think we'll start with some of those. Let's see. Someone asked, us being people who are immunocompromised, do we receive any representation of priority for receiving any of the vaccines? Yeah.
I think I made the point that you're not immunocompromised. You're living and thriving with HIV.
Wow. Great. Oh, thank you, Dr. Dieffenbach. I know earlier today, the MMAX newsletter came out, and Paul Kawada mentioned that MMAC had made a plea to CDC, yes, to raise people living with HIV into a higher priority category. Can you share anything about that, Moises?
Sure. I'll be happy. As you know, there have been all these categories and priority groups in order to move on with the vaccination, of implementing vaccination in the community. And just very quickly, we have the phase 1A, which is the phase for healthcare personnel and also for long-term care facility residents, right? That's the 1A. I think it's looking at 24 million people to be vaccinated under that phase, the 1A. Healthcare personnel, the long-term care facility residents. Then the phase 1B is frontline essential workers, people that work in hospitals, labs, clinics. They go under this category of 1B. And then people that are 75 and older are also to be vaccinated under the phase 1B, which is looking to vaccinate 49 million people. Then the 1C, which is looking to have like 129 million people, is in that phase. They are looking to vaccinate people that are aged 65 to 74. Also people that are 16 to 64, but that they live with a high risk condition. That is, the comorbidities we talked about. HIV is part of that, obesity, diabetes. And other essential workers that are not necessarily related to healthcare, but that are first responders, for example. So phase 2 is the people 16 and older that are not in phase 1. So INMAC has been concerned about the fact that, some people with HIV has gone to be vaccinated and they haven't, they have not been. They have been told that it's not their turn to be vaccinated. And also, ENMAC believe that people living with HIV should be in a higher category, not in the 1C, because, we are individuals that, even though we may be suppressed, we may have high CD4, the whole thing about, how can I say, things that predispose us to comorbidities like the inflammation or things like that, maybe it should be, good for us to be vaccinated at a higher phase. ENMAC, ENMAC reach out to CDC and other federal agencies to work on that, and hers as well. So we will see what comes out. Sorry.
Perfect. No, thank you. No, I have a question for Dr. Dieffenbach, and I have a couple of questions for Reg, and I think Lupina's hand was up. She may want to come off mute to say something. So Dr. Dieffenbach, Jeff Taylor wants to know, what plans are there to follow up with people living with HIV with the vaccine trials to measure durability of immune response, and people living with HIV recovering from COVID have more problems, and would they be susceptible to new emerging strains? He wants to know about follow-up with people living with HIV who've had the vaccine.
So let's take the first question first in terms of follow-up. As Reginald said, as a study participant, he will be followed in the trial for 26 months to assess the durability of the vaccine. That will be a component for everybody in the study. And from that, we will be able to see if there's a difference. At this point in time, there's no reason to think there will be. We are one of the concerns, because it's an unknown, is what the durability of the vaccine actually is. So that remains to be determined. You realize we're dealing with a disease that is about a year, maybe a month old at this point in time. The second question was, are there studies that are following people living with HIV and looking at the process of recovery and outcomes? And the answer to that is ongoing studies of groups like the MACs and the Ys are continuing to follow people living with HIV. The interesting thing about those populations, they're by and large well over 50. So again, they fall into other categories. They're probably over 65. They have comorbidities. And I'll say it again, the primary driver for most people is the comorbidities, not their HIV.
Okay.
Antiretrovirals are God's gift to us.
Yes.
It helps us live long, healthy lives. It requires adherence, as we all know, but the comorbidities are the issue.
Thank you so much. And Marcia Ellis wants to know, could Dr. Dieffenbach clarify if one can get reinfected with COVID?
That's a really interesting question. There are anecdotes about reinfection. And the issue with a virus is people are different. We're all different. And some people don't mount as good an immune response as others. And there is evidence in some people that there has been reinfection. I think that that again remains to be seen how long between infections. I mean, some of these cases have been very short, but again, that's what makes the news. What doesn't make the news are people that convalesce and are fine and go back to work and go back to their daily lives.
Yeah.
But we're watching all of this. I mean, this is a new disease, and we're trying to figure it out, and we're doing it at as fast as we can, as safely as we can.
Great, thank you so much. And I want to get a couple questions to Reggie and Linda. I know you probably see some questions that I don't see in here. Reggie, there's a question from Michelle Lopez. She wants to know, and I'm gonna put it along with my question. Now that the study's been unblinded, are you still in the study? And Michelle wants to know about phase 4. What are the phase 4 part of the trial that you rendered to you as a participant?
Okay, yes, I had the option on the 20th of continuing because the test went to a different phase. I had to sign another consent form that I was going to accept, be unblinded, and that I was going to continue. So yes, I am going to continue. I'm unaware of any other phase. All I know about is the one that I'm in.
Great. And do you know which vaccine you got, Reg?
Oh yes, Moderna. Yes,
Oh,
Moderna.
you did the Moderna.
I got
Okay.
Modernas. Yes, I got Modernas.
Great, thank you. Linda, did you see anything in here you want to ask? There's a lot of questions. Let's see here. In the UK, this is from Philippa. In the UK, people with HIV are part of the immune compromised group eligible for vaccines earlier than the general public. And they saying that due to some research in Europe, I'm trying to figure out what the question is. Oh, why aren't we part of the 1C group, especially those who have T cells before 400? It sounds like in the UK, they're in a higher vaccine than here in the United States.
In the United States, people living with HIV are 1C. That's what Moises said. And the point that Paul and NMAC want is to move up to 1B or 1A.
Correct.
With either healthcare workers or people over 75. That's the ask of it, as I understand it. Right, Moises?
Yes, you're correct.
So again, people under 65 are all who are living with HIV and don't have significant comorbidities are already elevated to 1C.
Okay.
Mm-hmm.
Great.
So may I ask, there was one question that flashed across that I think is very important. And the question was, do my anti-HIV drugs protect me from coronavirus?
Yeah.
And the answer is an emphatic no. They do not.
That was a good
HIV
question.
drugs are specific for HIV. The coronavirus drugs we have for now are the remdesivir that's given in the hospital and that monoclonal antibodies from Eli Lilly and Regeneron. And that's what we have to date.
Great.
Wahida, can you hear me now?
Yes.
Great, thank you. We do have a couple of great questions, but what I don't want to is skip past a couple of great comments that was in the chat box around the fact that a number of people noted, and we do know that not everyone is virally suppressed with HIV, right? So there are a number of people who immune system is much more compromised because possibly was a treatment lack of access, or we know that there are a percentage of folks in the US and around the world who just have not been able to reach viral suppression. So I think that part of what MAC is saying, we can't have one size fit all, as
Mm-hmm.
well as it's also in individual states as long-term survivors. And I think Mark King and a number of folks noted it earlier. We're advocates, we're leaders in this push. So if your state is saying something contrary to our need, I do think that we have to be in conversation with our HIV leaders at all levels of our local and state government as well to push us up there. So it's great that NMAC and nationals are doing that, but some of this also have to happen because yeah, where myself and others may be long-term virally suppressed, healthier than other family members who don't have HIV, that may be okay, but for other folks, it's not. The other thing that I noted in the chat, and we have two folks with hands up we want to call on,
Yeah.
is that we're talking a lot about HIV. Some people, because they're virally suppressing HIV, it might be those other comorbidities they need to address the healthcare system with. So HIV, even though it seems to be our big one, but in our health realm, HIV may not be the place to knock on a door when we're looking at our health and immune systems. Maybe it is someone who have liver disease or out of control diabetes and other things. Often we think of HIV, but in this case, it may be also making sure you're sharing a list of what those comorbidities might be. So I wanted to add that. I know Lapina's been waiting a long time. Maybe
Mm-hmm.
we can allow her to jump in and hear her voice. Is that okay with you?
That's fine. Calvin, can you find Lapina Reed?
I have her here. Oh, you
Oh, you
have
do?
her, Calvin?
Are you able to unmute her?
Maybe I'm not.
One of her questions was about if you about the new strains and if you already taken both dosages of the vaccine, is that going to protect you from the new strains? She could probably say it better than me.
Yeah, she's able to talk right now. Lapina, can you
Perfect.
talk with us? Unmute yourself.
Yes, thank you, everyone. That was my question. You know, there is a new strand of COVID-2 that's, I believe, in South Africa. And if that strand is happens to make its way here to America, and you've taken the two injections of the virus, will that suffice, or is that just, I guess you know what I'm saying, is that then will that be another strand that you would need another vaccine at some point in time? Thank you.
Based on what we know
Yeah.
today, the vaccine will protect you from the British strain, the South African strain, although the South African government has not asked us not to call it the South African strain. There's a California strain, and there's a Brazilian strain, and it seems to work against all four. Over time, the virus is going to continue to change, and there will need to be, like flu vaccines, additional shots to catch up with the changes that coronavirus have made.
Wow.
The companies are already planning for that and working on the next generation. But for now, the best thing we all can do is get these vaccines so we have a baseline of immunity that can then be built in catch-up vaccinations.
That's great.
Great.
Dr. Carl, can I ask a quick question? There's a couple of questions in the Q&A that talks about how do people with HIV get more involved in clinical trials that are not HIV specific? And is there a way, I'm gonna add this part, is there a way for NIH to push that as an identified population, particularly as we're long-term survivors, particularly as we're aging, and there are a number of health trials that are happening that will benefit from having a cohort that includes people living with HIV?
I agree with that completely. We push very hard to make sure that people living with HIV are included as soon as possible into all forms of clinical research. I get very upset when I see it as part of an exclusion criteria, particularly if it's a study that we as a division are involved with. So going back to the first tests of hepatitis C drugs, we really pushed very hard to get those studies into people living with both of those viruses quickly. And we, at NIH, one of the first studies we did was in Anacostia, Washington, D.C., to go to clinics there and engage community that were duly infected. We were able to demonstrate the level of clearance of their hepatitis C, and those people who engaged with us in that study became our biggest advocates in the community. And many of them ended up working at the clinic as volunteers to help recruit community members into other studies that we did. It's essential that we engage people living with HIV in clinical research.
Great, thank you. I have a question for Moises. Moises, many people are afraid to take COVID vaccines, right? It's the same thing with PrEP. Many people were afraid to take PrEP, even though we're offering these treatments free. What are the systemic barriers that are preventing people from wanting to accept this COVID vaccine?
Yes, you know, there is a long history of mistrust toward the medical field establishment from, you know, the majority of communities of color that have endured, you know, very negative experiences when dealing with the medical establishment. And, you know, these are examples that we have heard in the past, like the syphilis, the case of the syphilis studies, and the women in Puerto Rico that were given I'm forgetting the word in English, the pills that they take to prevent
PrEP.
pregnancy. You know, that they were
birth control.
Birth control, right? Contraception,
Yeah.
that's the word I was looking for.
Yes.
And, you know, they did it, they were a big study, and they gave it to them without them knowing. So there is, you know, being communities that have been, you know, all going under discrimination, or, you know, that have not have equity in terms of health. You know, we have health systems that are not working for us. There are, you know, health disparities in terms of diseases that are affecting people of color, and mostly African Americans, you know, in a different way that is, you know, not equal, because the system is not responding to them equally. So the problem, you know, the problem comes from that number of situations, systemic situations that these communities has confronted. And, you know, seeing that, you know, in the beginning when you were here, that not enough people of color were recruited in the studies, you know, people, you know, all these sense of not trusting just flare up. So
yeah. I certainly understand that. I certainly understand that. So we have a couple more minutes left. Dr. Dieffenbach, Mike Luella wants to know, he said he heard a comment in passing on CNN, and they were talking about people who were on blood thinners. What is the concern about blood thinners when it comes to COVID vaccines?
There's no concern with people on blood thinners with COVID vaccines. The issue with coronavirus disease, there may be some confusion, is there's a point in time during the coronavirus infection where blood thinners really help improve the outcomes of people who become living with coronavirus or infected with coronavirus. And then there's a point where it goes too far. where the blood thinners can actually cause a little bit of harm. So this is where the judgment of the physicians come in, and there are studies that were just reported out of the NIH specifically about when to use blood thinners in treating coronavirus disease.
Wow, okay.
That's your doctor knows that now. Yeah, hopefully they read.
We have 1 minute left. I want to ask Reginald, if it's okay, what was your family's response when you told your family you were going to go into the clinical trial?
As I said, my mother was a nurse practitioner, so healthcare was a part of my everyday life. So just letting them know, it's like, oh, okay, well, let us know when you know whether you got the placebo or got the vaccine. So they were 100% behind it. But like I said, I'm privileged that I never had that fear of that because my mother was a nurse, and I know that my mother would never do anything to hurt me. But I realize everybody is not in that situation, which is why I lead by example. That's all I can do. All I can do is lead by example. Here, I've been in all these studies, 6 or 7 so far, and I'm still here. So that's all I can do.
Thank you so much. And I believe that was our last question. We need to begin to close out. And thank everybody for attending, and thank all of our guest speakers here today. Thank you, Moises Augusto Rosario. Thank you, Reginald Brown. Thank you, Dr. Carl Dieffenbach. Thank you, Reunion Project supporters. We also want to thank our funders once again, which all of these are equally as important, but we want to really thank them. And again, we want to thank you all for supporting the Reunion Project. And we plan to have bi-monthly webinars. So our next educational webinar will be in March, and we'll be letting you know. In the meantime, if you have, I think we have a slide at the end. One more slide, Calvin, so folks can know how to contact the Reunion Project. Okay, because you can contact us by going to steering committee at reunionproject.net. Here we are. These are contact information for our presenters. They're a wealth of information. There are resources to you. We also have an evaluation that we really want you to take, so you can, I'm not sure, would evaluation go to them automatically, or you can access that evaluation. Maybe we can put it in the chat box so folks can click on it, but you will be receiving an opportunity to do an evaluation for us. Join us on Facebook. We have a closed Facebook page that you're all invited to join. If you want information from us, info@reunionproject.org. Follow us on Twitter. That is an underscore in our Twitter handle. So that is, follow us at Reunion Project at Reunion_project. And again, I want to thank everybody. I want to thank the program work group here at the Reunion Project for putting these bi-monthly webinars together. And I want to thank everybody who contributed to make this event a very successful event. Thank you all, and have a wonderful rest of your day. Have a wonderful evening, and stay safe.